This video, created for educational purposes, was developed by the Respiratory Monitoring Working Group, an educational arm of the PVI Network. In this video, we will explore the P0.1 maneuver, a simple bedside signal that helps you screen for low versus high respiratory drive during invasive mechanical ventilation. Why measurement of P0.1 is important. When we adjust the ventilatory support during assisted ventilation, we're balancing two risks: overassistance and underassistance. The goal during mechanical ventilation is to deliver adequate assistance. Overassistance can blunt respiratory drive and promote diaphragmatic inactivity, a phenomenon known as ventilator-induced diaphragmatic dysfunction. Underassistance can drive excessive effort, dyspnea, and patient self-inflicted lung injury. The gold standard to measure inspiratory effort requires the insertion of an esophageal catheter, an invasive procedure which is not widely available and not routinely performed in patients under assisted ventilation. The P0.1 maneuver is a simple, non-invasive bedside test that helps you screen for patient effort during assisted ventilation. The P0.1 maneuver guides us titrating ventilatory assist and the level of sedation to implement lung and diaphragm protective ventilation. P0.1 is the drop in airway pressure measured during the first 100 milliseconds of an inspiratory effort against an occluded airway. Interpretation of P0.1. If P0.1 is between 1 and 3.5, this is often considered potentially acceptable range. However, it should always be interpreted together with the clinical picture, ventilator waveforms, respiratory rate, tidal volume, comfort, and gas exchange. If P0.1 is 1 or less, this usually suggests low respiratory drive. This may indicate overassistance, excessive sedation, or very low patient effort. If P0.1 is above 3.5 to 4, this suggests high respiratory drive. This may indicate underassistance, dyspnea, pain, anxiety, fever, acidosis, worsening lung mechanics, or increased ventilatory demand. P0.1 directed ventilatory support. A P0.1 between about 1 and 3.5 is potentially acceptable range, but it should never be interpreted alone. It must be integrated with respiratory rate, tidal volume, patient comfort, gas exchange, and ventilator waveforms. If the patient is stable and has adequate gas exchange, proceed for further weaning of the ventilatory support and reassess the patient and P0.1 value. A low P0.1 value of 1 or less suggests low respiratory drive and may indicate overassistance, excessive sedation, or minimal patient contribution. In such condition, the ventilatory support should be reduced and/or sedation level should be reduced based on the clinical situation. Low P0.1 values has been associated with frequent failure to trigger, or what is called missed trigger, or ineffective effort and failure to wean from invasive mechanical ventilation. A high P0.1, usually above 3.5 to 4, suggests high respiratory drive and possible underassistance. This should prompt reassessment for causes such as pain, anxiety, fever, metabolic acidosis, hypoxemia, hypercapnia, or worsening respiratory mechanics. High P0.1 has been associated with dyspnea and worse outcomes in observational studies. High P0.1 values has been associated with patient ventilator asynchronies, in the form of flow starvation or work shifting, early cycling, and true double triggering. In this case, the patient is receiving pressure support ventilation, with a pressure support level of 7 and a PEEP of 5. When an expiratory occlusion was performed, the measured P0.1 was 3.8, suggesting increased respiratory drive and high patient effort. This increased work of breathing is also reflected on the ventilator waveforms. On the flow waveform, there is a loss of the normal exponential decay pattern of inspiratory flow. On the pressure waveform, this appears as a scooped contour, both of which support the presence of high inspiratory effort. In this situation, the operator should increase the level of pressure support to better match patient demand, while closely monitoring the patient's effort, waveform response, and the P0.1 value, to assess whether the intervention has improved patient-ventilator interaction. In this case, the patient is on pressure support ventilation, with a pressure support level of 14 and a PEEP of 8. When an expiratory occlusion was performed, the measured P0.1 was 0.7, suggesting decreased respiratory drive and low patient effort. In this situation, the operator should decrease the pressure support level to reduce overassistance and restore a more appropriate patient effort. Additional consideration should be given to reducing sedation, when appropriate. The patient's effort, waveform pattern, and P0.1 should then be reassessed to confirm improvement. For more practical monitoring educational materials, follow the Respiratory Monitoring Working Group at the PVI Network.